Hello, how are you, sir?
Yeah, you're fine.
Yeah.
That's good. Okay, I think I'll try and play that Chyluria video now. Let's see.
Could I be asking you some questions about Martin Luther?
Okay. Okay, then anyway, we'll wait till they join and then. Sure. Yeah.
So Martin Luther is like a Christian university, right?
Yeah, it's called Martin Luther Christian University. Not exactly a church. It's like an autonomous university.
Okay.
So they can have, I mean, it's not so much of Christian courses. It's a secular university, but mostly run by a Christian mission, the church in Meghalaya.
Okay.
They have the regular courses. They have a lot of online courses, big campus there, then the regular courses. They don't have medical courses, but nurse practitioners, community health courses, and so on, MPH and that sort of courses.
Okay. I see.
Have you heard of what is called deemed university?
D what?
Deemed university. So there are some universities have the status of what they call deemed university.
Oh, okay. No,
so they don't come under any of the big universities there. So they can have their own curriculum, they can have their own courses, and they have their own board for approval and those sort of things.
Yeah.
So special status universities.
Okay.
And they are ranked among the top 10 universities in India. In fact,
is that
last
right?
year they got 6th or 7th rank or something like that.
Okay.
I think Dr. Chyluria has also joined. So what happened to the patient that we saw last time we were discussing?
Yeah, so we sent him for PCNL.
Yeah,
he was seen yesterday by the urologist who will take care of him.
Okay.
So they will schedule him.
Okay, so PCNL should be a fairly okay option. But PCNL also they'll find it a little difficult because they need to locate and the orifice, then put in the open-ended catheter and so on. Unless they're doing PCNL using the ultrasound.
So PCNL, you do ultrasound, you poke the pelvis.
So basically, I mean, the thing is, you need to, I mean, traditionally when they started, you put in an open-ended catheter, then injected fluid so that the pelvis swells and the calyces swells up. And also you can use a C-arm to see the calyces. Then the shortest distance you puncture the calyx, then put a guide wire. Then you pass dilators over it. And then put in what is called amflash sheath. And then you put the nephroscope and break and take it. But then because you're dilated, if you release the dilatation, it will start bleeding. So you put a huge tube to drain the kidney. And after 1 or 2 days, then you can remove the PCNL, the drainage tube, PCN tube. But then that needs C-arm and then exposed to X-rays and all that. So then later on, some people develop the technique of locating the calyx using ultrasound. So because traditionally what happens is that you put the patient in lithotomy, put in an open-ended catheter, fix it, then turn the patient to prone position, and then do the puncturing. But then if you're able to do it with ultrasound, then you can straight away start in the prone position and proceed. What about Pylariasis? How common is it there in your place?
Not really so much. It's where I am, it's not
too very common. So I was asking how common is
so I was saying Pylariasis is not a big problem here.
Okay. What about hydroceles? Do you get a lot of hydroceles?
Oh yeah,
Hydrocele also?
hydrocele we do.
Okay.
Yeah, those ones we, hydrocele we get. Yeah.
So in areas where hydroceles and filarial legs are common, that's areas where you find a lot of Chyluria. Do you see much Chyluria?
Ooh.
Have you seen any patients with Chyluria?
No.
Okay, that's unusual.
Nope. No.
Right.
No. No. Yeah, the hydrocele we see are not. They are not massive hydroceles. They're just, and they are not too many. You can't say they are too many.
Okay, then you're lucky.
Yeah. Well.
Because still in many areas in India, we still have a lot of hydroceles. Even in Jharkhand, where I was last week, we had quite a few of them. And Pylariasis primarily blocks the lymphatics. Then when they're blocked, they try and form connections in other places. So that's why they sometimes get into the lymphatics of the kidney. So then the chyle leaks instead of going back into the blood circulation, it will come into the kidney and to the urine. So the way they present is like this thick milk-like urine, which is very high. It has a very high protein content. And sometimes there may be blood also. So that's how they present. So the way we diagnose is that you ask them to have a high fat diet. Like you give one big bread with a lot of butter. So then it starts secreting it about 10-15 minutes. Then if you do a cystoscopy, then you'll find from which side it comes. And what do you think will be the problems with the Chyluria? Because it's not a malignant, it's just a benign condition. So one of the common causes of Chyluria is Pylariasis. So basically, it's a connection between lymphatics, the intestine, lymph from the intestine, and the kidneys. They get joined. So because of the connection, then there is a leak of chyle or protein and substances into the protein and fat into the kidney. Okay. It comes out through the renal collecting system. And it is, as I said, it's a benign condition. It's not malignancy or anything. But what do you think will be the problems? Why does it need treatment?
Yeah. So because of loss of fats.
Okay, fat and proteins.
Yeah, fat and proteins. Yeah.
Okay, so whatever gets that. So one other thing is what will it cause? So it'll cause protein malnutrition because the chyle and the chylomicrons, they get absorbed from the intestines and then they need to go to the body. So we'll have low proteins in the blood.
Yes.
Okay, that makes them, what does it make them prone to?
Do they have less protein?
Yeah.
To protein, energy, and nutrition, that would be like kwashiorkor.
Okay, that is in children. And what about adults?
Yeah. Yeah, so.
Okay, one it causes malnutrition because we have less protein. It's similar to less protein intake.
Yes.
So, what are the other things which it leads to when your nourishment is not good? Does it make you more prone to?
Poor wound healing.
Yeah.
Yes. And
what about your immunity?
And immunity, immunity, of course,
Yeah. So a lot of the immune responses are due to proteins. So when you lack So, and they're more prone to urinary tract infection also, because one, they have less proteins and they have less ability to fight the infection.
Yeah.
And the protein in urine also acts as a good template for the bacteria to grow. It's like a culture media with good food for them.
Yeah. Yes.
So frequent infections. And the infection actually compounds the problem, because once there is infection, the block and the more of these lymphatic channels form.
Okay.
So then it keeps worsening the problem. So it definitely needs treatment, whether whatever be the cause. So what are the treatment options? How will you treat them?
Yeah. So is it DC, diethylcarbamazine?
Yeah, diethylcarbamazine, you can give a course.
Yeah.
And it's 100 milligram 3 times a day for 21 days. Thank you. But then that is not the entire treatment. They're not going to do anything to the channels which are already formed.
Yeah. So yeah, for the filariasis I have had experience with is for lower limb, and usually that is due to dead worm.
Yeah.
That's due to dead worm. So I'm wondering, is it the same for this intestinal one?
Similar. But then see what what diethylcarbamazine will do is prevent further spread of the disease.
Yeah. Right. Yeah.
Yeah. But then this connection which are already formed, you need to do something about it. So what do you think are the various options? See, if you want 100% cure, then what do you have to do?
I have no idea about that. I would guess maybe dietary management.
Dietary management, anyway, you need to, because they lose a lot of proteins, you need to give them more proteins. But then that doesn't help, because they keep losing it. So how will your idea is to prevent further loss. So how will you do it? Through the kidneys.
Through the kidneys.
So I'm asking about this. You may not have read about it, because that's the ideal situation. So a lot of times we cannot give the ideal treatment.
Yeah.
So what is the ideal treatment? How will you sort of?
I have no idea.
Okay, probably the only way of making sure that there's no connection is to disconnect all the lymphatic channels. So you'll have to dissect the kidney fully. But that is going to be a very difficult dissection, because a lot of these channels will be a very, very messy affair. And nobody advocates it, because they're not necessary. So what is the treatment they normally give? Did Chyluria able to hear now? We can see his pictures now. We're not able to hear you. We can hear some songs. I think it's your children singing, or Dr. Chyluria singing. Dr. Chyluria, you singing any songs? No. Still, they are not able to hear him.
Yeah, he must be having a very poor network.
Yeah. Okay, then going back to the thing. So that's dissecting the kidney out is too much of a over treatment or overkill for the problem. So what is the next option?
Yeah, but before you go to the next one, so by dissecting it out, you would dissect like the fat around it off of the kidney, or?
Yeah, you have to dissect around the capsule.
Okay.
So it's like how you do a donor nephrectomy, but only thing you don't remove the kidney. So
right. Okay.
Kidney.
Okay.
And you'll have to do the dissection right up to the mid or lower ureter, because the channels form all over the place. Okay. But the thing is, usually what happens is that it doesn't form all over the kidney. It'll be in some areas of the kidney.
Yeah.
Fortunately, there's 1 or 2 calyces which are affected, not the entire kidney.
Okay.
Okay. So then you go back to the next treatment. So what is the other treatment which is available? If you had gone through the video, you'll know.
Oh, no, I haven't looked at that one specifically.
Okay. So how do you block? Okay, let me go back to the Hydroceles. So is there any minimally invasive treatment for Hydroceles? Have you tried any of those?
No. No, not yet.
Okay.
So you're speaking about Hydroceles in general, or specifically due to Pylariasis?
I mean, both they can do it in general. In fact, a lot of the quacks do it. It may not be the surgeons.
Yeah. I know the quacks do aspiration, but...
Okay. Do they just aspirate or do anything more than that?
No, the ones who are not... The ones who run just quack clinics, they just aspirate.
Okay. They don't add any medicines.
They don't.
Yeah. Now we can hear Dr. Celia.
You can put tetracycline.
Yeah.
Yes.
So why do they put tetracycline?
Just to make the wall adherent.
Yeah. So tetracycline is one of those sclerosing substances which will cause addition between the thing. And the quacks get away with it because they introduce a little bit of bacteria infection. That itself causes some additions and prevents the hydrocele from recurring. Thank you. So that is, is it still available in Nigeria or Kenya? Injection tetracycline?
Yes, you have it, yeah.
Okay, but unfortunately it's not available in India anymore because that's a very good sclerosant. So what are the other places where you use this sclerosant? Again,
in the lung.
Lung, they don't put it too much.
Yeah.
Another common disease the quacks inject. They use the tetracycline. Did I say you?
Ganglion.
Huh? Okay, ganglion. Okay, any other thing which is much more common?
Effusion, pericardial effusion.
Huh?
He's talking about effusion, pericardium.
Okay, that is the quacks won't go near the pericardium.
Yeah.
So another common condition which the quacks treat in rural areas. Hemorrhoids. A lot of people earlier used to inject sclerosant for hemorrhoids. So tetracycline is one of the popular medicines which are used for that also. But then that is one of the reasons why Indian government has now banned tetracycline. You don't get those injections anymore. But it is a good sclerosant. And of course, it's also has bacteriostatic effect. Okay, so then if that is not available, what are the other sclerosants which are available?
Capsules, doxycycline, We have
liquid. We're talking about liquids.
oh, liquids. Okay. Bleomycin.
None of those medicines, unfortunately, cause that. This is much more commonly used medicines. In fact, one of the things which you use is almost every day you'll be using in theatre. So how do you clean the operative site?
Alcohol.
Okay, anything else? In fact, alcohol also can be used as a sclerosant. But what is the other commonly used solution for preparing the operation site?
You mean like Savlon, betadine, or is that?
Yeah, betadine. So betadine is another sclerosant. Povidone iodine, betadine. So that is another solution which can be used. Same thing. You can use it for Hydroceles, or you can even use it for chylomicrons or Chyluria. And earlier we used to use silver nitrate solution. So earlier what we used to do is to pass in an open-end catheter. First, of course, you need to diagnose which side it is coming from, because it's only usually one or two. Calyx is a small part of the kidney which is involved. So if you do is ask him to give a high-fat diet and do the scopy, you'll find out from which side it is coming. So once you identify the site, then you put in an open-ended catheter and then inject the sclerosant. Earlier, it used to be 1%, 1.5% silver nitrate, or 1:1 diluted betadine. Or if you have tetracycline, that also can be injected. And then leave for a while and then pull out the catheter. Then give them a diuretic. But what do you think is the problem with the method when you do this? So it causes sclerosis. It just basically it causes additions. It's a sclerosant.
Yeah.
It'll block the lymphatics. But what else can it do?
Can it also block like the ureters?
Yeah, so that is one of the dangerous things which can happen. Because if there is if the ureter lining is absolutely good, no damage, nothing, then you might get away with it. But then once you're passing the catheter, the ureteric catheter, it can cause minor damage or infections or minor tears. So those areas, it can cause severe fibrosis or sclerosis. Then you can get ureteric strictures. And sometimes the entire length of the ureter can be strictured. And that can be quite serious, because if you don't realize it, if you're not able to pass any tube or catheter or stent or anything, then you might even have to replace the ureter with ileum, which is quite a major surgery and quite a big procedure for as a result of stricture.
Yeah.
So then, so how do you prevent this from happening? So that is why they don't inject large amount at one time. They inject little bit, and also try and give a diuretic so that it's washed away quite well. Of course, then still it is a blind procedure.
Yeah.
Because you don't know which of the calyxes which is coming from.
Yeah.
So from your knowledge of what you have been learning so far, is there any other better way of doing it? So basically you want to put the sclerosant in the calyx which is affected.
Yeah.
So how do you do that?
Ureteroscopy with
So what we do is, first, of course, you can't straight away with the URS go into the kidney and calyces. So at the first stage, you put in a DJ stent, wait for the ureter to dilate. Then once it's dilated, about 6 weeks later, you can go in with the URS and observe from which calyx the chyle is coming from. Because once you're in the pelvis, you can turn around and look at all the calyces. And you'll be able to identify 1 or 2 calyces from which this chyle comes. And you can specifically place the mouth of the opening of the URS at that calyx. And then inject any of the 3. If tetracycline available, it's a very good one. Otherwise, 1:1 betadine or silver nitrate solution. And then wait for some time there. You can actually, these things, although it takes a little while for the final effect to come, even if you wait for a short while, you know that it temporarily blocks these lymphatics, either the betadine or this thing. And you'll also know, can give a much higher concentration of it at the right spot. Then rest of the calyces and ureter and pelvis, you can wash with normal saline. So this is a much safer way of doing it. But again, because it still doesn't give 100% cure, because it's only in about 50-60% of the time these sclerosants work. So you might have to keep repeating it till it settles down.
Okay. How big is a ureteroscope?
It has, there are 2 sizes. The bigger one is 9.5 French. The smaller one is 7.5 French.
Flexible?
No, it's not flexible. I'm talking about the rigid.
So,
you can use flexible also, but flexible is much more expensive.
Okay.
And that is about 12 to 13 French in diameter. So
how long would it have to be? How long would it have to be? How long is it?
The length, you mean?
Yeah.
Length is about, I think, 120 centimeters, 120 centimeters, something like that. It's a fairly long one, so it has to go from the urethra all the way up to the kidney. And
it's possible to go through the penis?
Yeah.
Even if it's rigid all the way to the kidney?
Yeah. See, that is we have been removing the renal stones with the URS because of that.
Okay.
So traditionally, nobody, either they use flexible ureteroscope and laser for breaking. But then use of laser for breaking is a very slow process. Of course, one thing, it is very expensive. The scope is expensive. The laser fiber is expensive. Everybody had to wear the special goggles and all those things. And it takes a long time for laser to break the stone.
Yeah.
But rigid, you can break it with lithoclast, which is, even it costs about $1,000, the ordinary lithoclast. So that can break the stones very quickly.
Okay.
So, if it's a 1 centimeter stone, about 5-6 minutes, it can break with the lithoclast. But to break a 1 centimeter stone with the laser, it'll take about 45 minutes to 1 hour. And but the thing is, normally it is used, the various curves. So it starts from the kidney, then curves like that, then goes like this along the pelvic wall. So all these things have to be straightened before you the URS. And also the ureter has to dilate sufficiently.
Yeah.
So that is the reason why we leave a stent first. So you put in a DJ
for
stent.
6 weeks.
Yeah. So when you put, it'll be just enough for this, it'll allow the stent to go. But then 6 weeks later, you'll see that even with the stent, you can pass the URS along with that. So it dilates 2 to 3 times the original size.
Okay.
And then you have to again position the leg in such a way that the curves are straightened. And you might
How do you
have to
do that?
sometimes the position of the leg in the lithotomy. See, one leg, the opposite leg, you put it in full lithotomy and turn towards the other side. This leg is almost semi-extension, and make sure that the curve in the back also is straightened.
Okay. Okay.
And then the most important thing is you should not pass the URS blindly.
Yeah.
You need to gently pass it under vision. And if necessary, you can tilt and make the adjustment to pass in the vision. So if we have a little experience, it's fairly easy to do.
Okay.
And once they're able to reach the kidney, then you can use a lithoglass to break the stones. And if the stone is in the calyx and it doesn't come out, then you can tilt the patient. You can have the patient head down or rotate or head down, depending on where the stone is. You can manipulate the position of the patient to make the stone visible.
And the litho, you're calling it a lithoplast. How does it look?
Lithoplast is, actually there are two types. One which works with the compressor. It is basically what it has is that it's a big rod which goes through the URS and hit the stone. And then there is a small portion, the handle, where there is a bullet. So what happens is that the machine intermittently releases gas, which pushes the bullet. So the bullet go and hit the rod.
Dr. Salyu.
Yes, sir.
Yeah, there's too much background noise.
Okay, can you hear now?
Yes.
Okay. So what happens is that the handle has a bullet. And intermittently the gas is pumped into the bullet. So the bullet goes up and hits and comes back the rod. So this is passed on to from the rod to the stone, and it breaks the stone. But then why doesn't it injure the kidney tissue or the ureter or whatever it is?
Is it a technique issue? Is
Not
it because
exactly
of the
technical, of course. If you poke it, it'll definitely injure. So how does the lithoglass break only the stone and not the renal tissue or ureteric tissue?
No
so
idea.
What is the difference in quality of the tissue?
Well, the stone is calcium, so it's hard tissue.
Okay, in physical property. So
okay. The tissue
what is the
would
difference?
be tissue is more pliable.
Okay, so the elasticity, the tissue is an elastic structure. So if the wave hits it, it just move away and come back.
Yeah.
But stone on the other hand is brittle. So because it's hard and brittle, so if you keep on tapping, it will break. But then there are two things you need to be careful when you're breaking the stone, because if you hit it from a distance, the stone will keep moving away. So if the stone is in the pelvis, then it's here. So you have to press it against somewhere so that it doesn't move. At the same time, if you press it too hard and hit it, it can make a hole and go off. It can cause perforation. So that is why you need to have the experience of how much pressure to apply, how much force to apply, and where to hit the stone in such a way that it doesn't cause any problem.
Okay.
But then treating this one is far more easier, because Chyluria, you can go to the kidney and look at the various calyces, and you know from which calyx this whitish stuff is coming from. And they inject the sclerosant into that calyx.
Okay. So the ureteroscope has a working port.
Yeah, it has what is called a working port. So it has this thing for irrigating. You can one inlet, one outlet. Then the working channel is about 4 to 5 French in size.
Okay.
Okay, how do you convert French into centimeters? Say, because you're talking about French. So
yeah, you use pi for conversion. You use pi 3.14. So for example, 7 French would be about 22 French. I mean 22. Wait.
Okay, roughly it's actually 1/3.
Yeah.
So 30 French will be 1 centimeter.
Right. Yeah. Yeah. Okay. So if you had a choice for the last patient we talked about, extracorporeal.
Yeah, ESWL would be the easiest because if it's available, because it's a smaller stone and it can break quite easily. How does the ESWL work?
It's through the skin, it's through tissue, right?
Yeah, but then doesn't it damage the rest of the kidney or the tissues it's passing through? Or
no, it doesn't, because of the nature of the tissue. I've never seen one, let me say that. So just
again, it's similar. So see, again, the thing is because the stone is brittle and while the tissues this thing. But ESWL, what happens is that they have a big structure. It comes in many directions and focuses near the stone. Okay. And ESWL, the other thing is it also needs a little bit of fluid around it for the stone to move around once it breaks. And also to visualize it properly. Because only if they have fluid, then it's easier to visualize it by X-ray. And again, the traditional ESWL, you use X-rays to visualize.
Yeah.
Well, then some of the newer ones again use ultrasound. But ultrasound, again, you need to be an expert in doing the ultrasound to sort of localize and break the stones.
Okay. So you do up to size 1.5?
Which one? ESWL. Is ideal for about 1 to 2 centimeter size stones.
Okay.
See, up to 1.5 centimeter, in fact, up to 1.2, 7 millimeter to 1.2. Just a stenting should suffice. Because ureter dilates to about that size. And up to 1.5 centimeters also can come occasionally. But beyond that, if ESWL available, that is the best. Or you can do the URS and break it, because even PCNL, the problem is you still have to drill a hole through the kidney. So that does have, of course, it damages a few of the nephrons, 100 or 200 nephrons. But more than that, the problem is that there can be bleeding from that area. So you can go through blood vessels, and kidney has a very rich blood supply. Almost 25% of the cardiac output goes to the kidneys. So it's a very highly vascular organ. And if it bleeds, especially if there is secondary hemorrhage, it can be quite serious. So that is the drawback of PCNL. So now they have what is called mini PCNL. See, earlier they used to dilate up to 1 centimeter to put the nephroscope. So now they have these smaller scopes, which is almost similar to the size of URS.
Mm.
But then that can be, I mean, there the thing is, you don't have to dilate the tract up to that much. So half of this thing. But then it takes longer time to break the stone.
Okay.
And one other thing he can do is if he just buy those dilators, even during the open surgery, it may be safe to do that rather than do an nephrotomy. See, sometimes what happens is that you'll have a large pelvic stone and very small lower calyceal stone, and the infundibulum may be narrow. So through the pelvis, you won't be able to remove the stone. And sometimes if it is intracranial pelvis, the pelvis also is very small. So it'll be difficult to manipulate a URS or something to go into the lower calyx and break. So that time what we do is if we can feel the stone, you hit the stone, put a guide wire, then use dilators and URS and break it. And there the advantage is that you can suture the capsule of the kidney. So that gives a little bit of pressure. And you can, the bleeding will stop. Okay, staying on this subject of Pylariasis and Hydroceles and all that. Why is hemostasis so important in scrotal surgery?
Yeah.
So one other thing is you're really almost mortally worried about is the infection, and once there is infection in the scrotum, it can be very, very bad.
Yeah. So yeah, one thing is the infection, but the other reason is you can bleed. Well, if there's no hemostasis, the scrotum can hold so much blood.
Yeah.
Yeah.
Why is that? Because see, other places, it's other tissues. Pressure is one of the important thing which stops the bleeding, especially the capillary wounds. If the pressure is not there, especially like in places like scrotum, it can really bleed and swell up quite a bit. So that's why even though it is a simple surgery, the surgery by eversion of the sac, whatever you do for hydroceles, can be quite a messy surgery if you're not done properly.
Yeah, sure.
So, and if we have something like a vessel sealing, it's better to use vessel sealing for it rather than the regular cautery or rely on sutures to control the bleed. And if you don't use vessel sealing, then the other thing is all the cut edges, you do a continuous suture to give some compression so that it doesn't bleed.
Okay.
Did I say you, how is the connection? Are you still able to hear us? Or? Okay, we're not able to hear him, but I hope he's been able to hear us.
Yeah, seems like you can hear us, but we can't.
Okay. So, Dr. Elijah, can you just sort of summarize what you've been discussing?
Yeah.
Because he joined a little late. So.
Yeah. So we've been discussing about filariasis and the cause of Chyluria. So Chyluria happens in intestinal filariasis. So there's a blockage of drainage of lymph from the gut, and what happens is the lymph tries to get a different pathway and drains out through the kidney. And once it drains out through the kidney, then now you have Chyluria. So we were discussing our management of that, and because it's important to manage because patient loses a lot of proteins and fats.
Okay.
Yeah. So the available options include getting to the affected, affected calyces. Calyces are the lymph is draining into, and injecting sclerosant. That's preferred as opposed to blind instillation of sclerosant, because blind instillation has a risk of also sclerosing the ureter as well. Yeah.
Okay, that's in short about. Then we are discussing about URS. Why is how is URS possible?
Yeah. So URS is done with a ureteroscope, which is about 9 French or 7 French, 9.5 French.
And 7.5. So.
And 7.5, yes.
Okay.
9.5 and 7.5 French. So the most easily available, of course, is the rigid one, but flexible is more expensive. So you have to position a patient appropriately, and before you do it, okay, but first of all, before you do it, you have to stent the ureter so that it can expand. So the stenting is done for about 6 weeks.
Yeah.
Then during the ureteroscopy, position patient appropriately, go to the bladder, find the orifice, work through the curves of the ureter, and go all the way to the kidney. And then if you are treating Pylariasis at that time, I mean Chyluria, you can identify the calyx with the drainage and instill the sclerosant to the specific calyx.
So the skill that you can learn is, if you
so
have
we can
just
easily identify the place where the Chyluria is coming from.
Yeah.
Yes, you can.
You can see from which calyx.
Okay.
See, usually generally it is from the lower calyx. So that is where a lot of lymphatics are there, from the intestines which come. So if you have just a laptop cystoscope, what you can do is, if you don't have it, just tenting the patient, leaving for 6 months, 6 weeks, then taking it out and injecting the corresponding kidney also is a better option, because if you leave the stent, it dilates. So even if it causes a stricture, it doesn't become very narrow. So even if you don't have a ureterinoscope and they still want to treat Chyluria, it is a better option to first stent and 6 weeks later inject the sclerosant. But then the chances of stricture are much less.
Yeah.
Okay, any specific questions you have in another few minutes? So. Any questions?
You said if you do a lithotripsy, breaking down of the stone in the kidney, you said we must apply pressure to the stone.
I'm not able to hear you.
You're breaking up.
The voice is breaking. We're not able to hear you.
You said the too much on the stone. How do we gauge the pressure?
I think we still didn't really. If I understood, you're asking how we are breaking the stone. So we use a lithoclast. There is a lithoclast has 3 components. One is a long rod which goes through the URS. It's about 4 French and it'll touch the stone. In the other side of the rod is a slightly expanded portion, and it's inside a tube. The tube has a bullet which comes and hits like a hammer. It keeps hitting the rod, and that happens because the machine produces jets of either compressed air or oxygen intermittently, which makes it bang on the thing. So that makes the stone, which is brittle, it breaks it slowly. But I don't know whether that was the question he asked because we're not able to hear.
Yeah.
Okay, the other thing is, please go through that one.surgery website and complete the lessons and the questions there.
Yeah. So the videos you had wanted
which one
to be liked, the videos you had requested that we like.
Yeah.
They're the ones on the YouTube or the one on the
and
one
the
side?
YouTube. In the YouTube.
In the YouTube. Okay.
Yeah.
All right.
The links are there in the lesson. So from the lesson, if we click, you go to
have the recording of this lecture. Can we have the lecture, the recording of this?
We'll put all these. All these we'll put it in this thing because he has a lot of pending videos to upload. Okay, so about 20 of them are there. So once he finishes, then he'll slowly upload all this because we're recording all these, then they'll be available.
All right. Thank you from me. At least I've learned something I never knew or never heard about.
Okay, then it's good they're able to learn.
Yeah.
Okay, then have a great weekend. We'll see you next week. Bye.
All right. Bye. Thank you.